Well, good afternoon, everybody, and thank you for joining us. We've got another fantastic education session. Today we're going to be talking about everything with syringe drivers. I'm Sandy Vincent from the PHN Education team, and I would like to start off by acknowledging the traditional custodians of the land that we live and work on. For us on the Central Coast here, we're in Darkinjung land, and pay my respects to elders past, present and emerging. We're going to have a question and answer session today as part of this program, and my colleague Charles Broadfoot will be joining us for that to facilitate that. But it is my extreme pleasure to introduce our speaker today, which is Tara Clubb, who is a clinical nurse consultant from the Central Coast Local Health District. And it's really a pleasure to have you with us today, Tara. So thank you so much for joining us.
Thanks, Sandy. Hi everyone, so thank you to Sandy for the introduction. So as she indicated, I am a clinical nurse consultant for the Specialist Palliative Care Service based here on the Central Coast for Central Coast Health. I support the palliative care clinical nurse specialists that you will see coming into your facilities. My background is predominantly prior to my palliative care experience was in the hospital, so I worked in oncology, haematology was my background, specialised in palliative care and have been a palliative care specialist nurse for a couple of years and have been the clinical nurse consultant for the last 5 years. So I come to some of your facilities from time to time, so please don't be shy and say hi. So as Sandy indicated, I'll be talking to you about syringe drivers today and a little bit of what to expect from our discussion today. So I'll be doing a fair bit of talking. I will interact with you at times and ask some questions. So please write them into the chat box if you have any questions, and Charles will kindly read them out to me when we need to. So I'll be talking to you about what a syringe driver is and when we use them, the benefits, the risks and some of the safety implications involved when looking after a patient with a syringe driver, the actual how to actually set a syringe driver up. So I have a small video to show you throughout the presentation that you can return to when needed in the future. Otherwise, I will also be giving a slower practical demonstration as well about how to set up the syringe driver. Some of the observations and the checks that are expected when you're looking after a patient with a syringe driver, and to ensure that they're running correctly and the patient's symptoms are well controlled. So we'll talk about that. And then a little bit about troubleshooting as well, because technology isn't always in our favour and sometimes syringe drivers, like everything else, can malfunction. So how to deal with that as well. So to begin with, as you'll see on the screen, this is what your syringe driver should look like that you have received. So these are the BD Bodyguard T syringe drivers. If you've ever looked after a patient with a syringe driver in the past, you may have looked after them with what's known as a Nicky T pump. They are essentially the same thing. The buttons look ever so slightly different, but in theory they are the same machine. So they are small. As you can see, they're approximately around about the 20 centimetres. They are battery operated, so no plugs, completely cordless. They are therefore portable, so people can still mobilise around with them. You don't need to worry about having to plug them into electricity at all. And they deliver subcutaneous medications continuously. So usually that is over 24 hours. However, the machines can be recalibrated to run over 48 hours up to 72 hours ever if needed. We have done so in the community when we've had people that have chosen to go away overnight. So if you've ever have any residents that are in that particular category, they can be recalibrated, and that's something that the Specialist Palliative Care Service would be able to assist you with if that was required. So with syringe drivers, in essence, I suppose very briefly, medicines are drawn up into a syringe, which I'll show in a demonstration later. That syringe is then attached to the driver, so it sits on top, and it's set to move by a plunger that's at the rear of the syringe, and that pushes it forward at a very accurately controlled rate. So that ensures that the precise dosage is administered every hour. Now, when you're running a syringe driver, usually around about 0.63 mils an hour is the usual when you're running about 15 mils of fluid in the syringe driver. But again, I'll show you that in a later demonstration. Syringe drivers can also be placed into carry bags or a pouch when we have patients that are mobile. A lot of palliative care, our service has syringe driver pouches that have been very kindly made and donated to our service by volunteers. So it's something we normally have an overflow of these carry bags because our volunteers really enjoy making them. So if you ever are in need of some, please reach out to the palliative care service and we can see what we can do for you in donating you some of the carry bags. However, they can also be tucked underneath a pillow if patients are bedbound. So we try to encourage them to not be in the way of accidentally being knocked or dropped over the side of the patient's bed as well. So tucked underneath a pillow is normally a safe bet, particularly if someone's being rolled or if they're quite agitated. But if the patient isn't experiencing any of that, just sitting obviously beside them and ensuring that the line isn't kinked is always best practice. So when can a syringe driver be used? So obviously you need to have accredited staff. So your facilities will be going through with you obviously attending these training sessions and possibly interacting with the provider of the syringe driver as well. Central Coast Health have accreditation processes where nurses have to be re-accredited every 3 years to safely administer syringe drivers. So that may be something that your facilities may need to look at for your team members. But the reason why people need to be accredited is obviously because if you don't know how to use the machine, then we can head into a dangerous territory because we're dealing generally with S8 and S4D medications within them. But mostly for medications that cannot be tolerated orally. I'll explain in another slide, but that is the essence of them, whether that is for end-of-life care or for symptom control. And always remembering they are a nursing tool, so they don't provide any better pain relief than any other method. They are purely a nursing tool, which I'll explain. So a list of the indications for nurses and GPs of your facilities for why you may need to start a syringe driver. So again, as I mentioned before, being unable to tolerate medications orally. So that can be due to nausea and vomiting, can be a significant cause. Some people who have had things like chemotherapy or radiotherapy or have disease such as a oral cancer can have significant oral lesions within their mouth, and actually swallowing anything, whether it be medications or fluid intake, can be extremely painful. So sometimes we do have to revert to syringe drivers as a means to manage that. So that can include, like I mentioned, mucosal ulcerations, so from treatment options or from cancers. Dysphagia, so that inability to swallow, whether that be from obstructions or muscle weakness as people have deteriorated. generally as people are entering what we refer to as the terminal phase. The swallowing reflexes are hindered, which is a natural process of the dying process that our brain induces. So the muscles of our throat don't work well and they don't close and relax appropriately. So swallowing things is difficult and can cause aspiration. So when we have people at those aspiration risks because of those swallowing difficulties, we may need to use a syringe driver. Weakness, again, that's more associated with the dysphagia, so weakness around the swallowing reflex, and then obviously sedation or comatose, so people who are not alert or awake enough to be able to tolerate their medication. So there may be, opening their eyes and still able to interact with you but unable to obey commands, or are so drowsy they're falling back to sleep. Again, where that risk of aspiration is significant, we may look to put people on injectable medications to manage their symptoms. The next thing is that there is poor absorption of the oral medicines. So that can be for a number of reasons, usually to do with the gastrointestinal tract not working effectively. So therefore, medications are not being absorbed by the body appropriately. That can happen because people have things like, for example, diarrhea or constipation. So when people have diarrhea or constipation, they're not the medications that are going into their gut are not being absorbed appropriately. So effectively what we're doing is we're bypassing the gut by giving the medications injectably. Or, for example, their pain isn't adequately controlled by the oral medications they've been administered. So it may not just be pain, it could be any other symptom that we're trying to manage orally, but the oral route is just not as effective for some people. We have some patients that for some reason, that ones particularly that have significant symptom burden, so very high pain, very high things like nausea, for example. And we've been using oral medications. Sometimes they're just not very effective, and then as soon as we've switched them to an injectable version, their symptom control is improved. Sometimes we don't actually know why, but that can be an option. If we've tried oral, it's not working, we've got escalating doses not working, we may need to switch to injectable versions. Another reason is that there is a bowel obstruction. So I've got here malignant bowel obstruction, so a cancer that's occluding a lumen of the bowel that is blocking off the actual intestine that prevents any, whether it be food, fluid, faeces, etc., moving around that obstruction. And what happens is if we give people, whether it be any form of oral medication, when there's a complete blockage, you'll have that pressure being forced up against the blockage, and therefore that causes significant pain and symptom issues with that. So when anyone has a bowel obstruction, completely remove everything orally. That includes food and fluids, because again, they would have the same symptoms. So sometimes the reason why we may need to do it is not only because they've either not appropriate for surgery or they've refused surgery, so we're just managing the bowel obstruction as it is. Sometimes we do have Salem sumps or nasogastric tubes inserted for these patients, and if we were to be giving them oral medications, effectively we're putting in the oral medication for it to just come straight back out the tube. So again, bypassing the gut by using the injectable version of the medication. So some of the benefits and the safety of using a syringe driver. I go into another slide about some of the disadvantages, but in essence, these are the significant benefits. So they can generally be less time consuming. So they're only changed every 24 hours instead of needing to go to the cupboard every 4 hours and remove that medication and find 2 nurses to check it, sign it out, draw it up, etc. You're doing it all at once, so it can reduce that the time management as opposed to if you were doing it any other way. It also allows multiple medications to be delivered at the same time. So I've got here up to 3 compatible medications. when specialist palliative care is involved, we can go higher than that. We can sometimes put 4 or 5, depending on what that patient's symptoms are. But if your GP is solely managing it, then we normally don't recommend any more than 3 compatible medications. I have a list as well of those compatibilities, which you can refer to at another time later in the slide. It's also good for people, again, like I mentioned, unable to tolerate oral medications, so a great bypass for the gut. Increased comfort because we're not needing to give them as many intermittent injections. So obviously, in most cases, you would have another butterfly inserted for a patient, so we're not giving them a needle every time we're giving them an intermittent breakthrough, but we're not having to necessarily wake them or pull the covers back, etc., to be able to deliver those medications every 4 hours, particularly overnight, so it minimises the disruption that we cause to a patient or a resident when we need to do that. It also avoids wastage of medications. So as you would know, obviously you're removing medications, S8 and S4 medications from a cupboard. You're only able to draw up what's required and what isn't required for that PSA. For instance, if you were giving it every 4 hours, it's 1/6 of the dose that would be going into a syringe driver pump. So every time, say for instance, you're giving a patient 5 milligrams of morphine at a time and your vials are 10 milligrams of morphine every time, you're needing to discard 5 milligrams of morphine after every time you're drawing up those medications. Where if we were to give that 5 milligrams of morphine to that person in a syringe driver, we would times that by 6 and give them 30 milligrams. So you would use 3 full vials to put into the syringe driver pump, as opposed to wasting half of 6 ampules every day. And then obviously it can also allow for better symptom management and avoiding those peaks and troughs that patients experience. So I don't know about you, but working obviously in a hospital environment and similar to the residents that you look after, I'm sure when you have patients that have been on 4th hourly medications, very rarely are they being given those medications right on the 4 hours. We're normally looking after a multitude of patients at the same time, so there is, in 99% of cases, there is always a delay. Now, what happens is if we were to give patients those medications outside of that 4 to 6 hour window, we're effectively losing the traction and the gain of the pain relief we've had, and we're having to start again. So we're not needing to do that with a syringe driver because it's giving a continuous flow and pump of that medication over a 24-hour period instead of having the peak, trough. So listed here are the, again, highlighting some of the advantages that we spoke about and then some of the disadvantages. So I will run through the disadvantages. Again, you can read the advantages if you wish, and we've already discussed them. But normally, some of the disadvantages are that we need to anticipate what that patient's dosage will be over that 24 hours. So if we don't actually know what a patient's analgesic or symptom relief requirements are, then it can be very difficult to determine that, and then it's harder to then, we've got to wait a full 24 hours before we can then increase a dose. We normally don't increase dosages in short of that 24 hours. However, when someone's on 4th hourly medications, we can effectively increase or decrease medications every 4 hours because we're able to get a really good idea of what that patient's requirements are. So in most cases, sometimes we do have to start off with regular intermittent medications and then move to over 24 hours once we establish what that patient's 24-hourly analgesic or other symptom control medication requirements are. I've got here medicines given by other routes that need to be subcutaneous. So there are some medicines that are unable to be given subcutaneously, or they need to be separated. They can't be, they sort of don't play well or play nice with other medicines. So that can be a difficulty as well, where we may have to sometimes run 2 separate syringe drivers because we're needing to use a medication that is incompatible with other medicines, for example. It can also increase a patient's symptoms, and they may need additional injections for relief. So obviously what I'm referring to there is, for instance, a patient may need to have morphine, hydromorphone, etc., put within their pump for analgesic effect, but they may experience nausea as an adverse effect of that medicine. So therefore we may need to give them regular intermittent breakthrough antiemetics to try and combat the symptoms that the medicines that we're giving them are potentially causing. So that can sometimes can be a risk as well. We also have risk of local site reactions. So some people's skin doesn't interact very well with the medicines that we deliver. Some people have very sensitive skin. Some people who may have conditions where they're immunosuppressed, so they're much higher risk of developing inflammation, redness, the line tissuing from their skin. So all of that obviously is a risk. It's another a body, an opening within the skin that can introduce infections and bacteria, etc. So although it is going into the fat layer of the skin, people can still develop things like phlebitis and cellulitis and significant infections. So always something to have in mind. And also, we obviously face the stigma that patients and family members what they think syringe drivers can do, or what they do. So a lot of people, patients and families, or residents and families, can be very resistive to syringe drivers starting as a result of that stigma, which I will talk about in another slide. The other thing is that they are not a set and forget device. So a lot of people have in the past assumed that running a syringe driver, that it runs over 24 hours, so we don't need to do anything. You still very much need to assess a patient very regularly, ensuring that the pump is still running, the line isn't kinked, no problems are happening, the patient's symptoms are still well controlled. Because as I said before, that patient's symptoms may be increasing within that 24-hour period, and if they're not reviewed or assessed, we're not going to know. And then obviously we can be leaving people in significant discomfort. So talking to about syringe drivers with patients and families, it can be difficult. As I mentioned before, they can be very unwelcomed. Some people are very, very resistive to them. We obviously need to try and discuss with them the goals of administering via a syringe driver, and the importance of why we're needing to do that. And, simply saying to them a syringe driver is just an alternative route to deliver the same medication that they're generally already having. We're not, in most cases with syringe drivers, we're not starting people on a syringe driver and starting things like morphine, midazolam, etc. If they haven't needed it prior, we're generally not needing to just start it for no reason. So they've normally always been on a background. So it is about letting families and patients know we're just effectively replacing what's going in orally. And then also sometimes people can revert off syringe drivers. So we have had people that have been on syringe drivers and we have taken them off them, particularly if they've been needed for symptom control of something like nausea and vomiting, and not for end-of-life care. So it is always something that can be removed potentially if the patient is appropriate for that. So topics of discussion can include, sometimes a lot of it is patients or family members who have had past experience with syringe drivers, so they've had another family member that's utilised them. I've heard language such as things like they're the death box, as soon as my dad went on that before, he died a few hours later, etc. So people have, we haven't developed a great reputation with them necessarily because of what generally comes after people have commenced those syringe drivers. So that is sometimes we're needing to get past that barrier and that previous experience that people have had, or sometimes that trauma that people associate with the syringe drivers. Talking with them about the stage of the illness the person's at and why we're needing to use a syringe driver. So, what that means for their future, so their prognosis. So, in a lot of cases, in majority of cases, we are using syringe drivers for end-of-life care. So it is about letting people know that, yes, this person, your loved one, will end up dying. In palliative care, we don't like to use the word passing away. It's effectively a euphemism. So you'll hear me talking a lot about dying, death, using that sort of language, where it's obviously where appropriate in most scenarios. But letting people know that yes, your loved one will end up dying, but not as a result of this medication or the use of the pump, and reminding people that if you didn't use the pump, they would still die anyway. The pump is just purely a means of providing symptom control. Again, reassuring, it doesn't always mean that death is imminent. We've had people that have needed to be on syringe drivers for symptom management rather than end-of-life care. So some people have been on syringe drivers for many weeks and months. It doesn't necessarily mean that they're going to die within the next few hours or even that day, the next day, even that week. So it's not an indicator of imminent death. Again, as I highlighted, explaining that the syringe driver allows the symptoms to be managed that are associated with dying. So death and dying itself is not a painful process. You don't develop pain just because you're dying. Most people develop pain because they already have pain. It's an existing reason for having the pain. It's not because death is causing the pain. The only thing that people may experience when we refer to as pain when they're dying is because their inability to reposition themselves. So people can become uncomfortable because they're obviously laying normally in a supine position. So that's why the importance of pressure area care whilst people are dying is so important to prevent that symptom from occurring. But also, again, encouraging it does not speed up the process of dying. So in a lot of studies that have actually been completed, syringe drivers in a lot of cases will actually increase people's life expectancy rather than shorten it, only because their symptoms are actually better controlled. So the theory says that people who have unmanaged symptoms will likely die faster than people who have managed symptoms, and effectively that's what a syringe driver pump is doing. We're managing the symptoms that are associated with either their illness or because of their dying phase. People can become agitated because they are dying. Sometimes we don't know why. The most common cause of that is normally urinary retention or constipation. However, if it is terminal agitation, which again is a death phenomena, we can use midazolam in the pump to help settle people and calm them down during that process. Again, addressing any fears about the syringe driver or the medicines that are used within it. So opiates, for example, are obviously the main reason what people have concerns about. People have concerns that they will become addicted or their family member will become addicted to things like morphine. So just reminding people that we're using it for a reason. There is a symptom that we're treating. Normally addiction comes with people who are using medications when they're not required. There's not a nerve response being triggered by the body that requires that medication to respond to that neural pathway. So the likelihood of people having addictions, particularly at the end of life, is very, very minimal. There's pretty much no research on it because addictions generally build up over time, and there's normally other indications that can get involved with that. So just putting people's mind at ease about the very unlikelihood of those things happening. And then obviously, discussing advanced care planning options or if people have advanced care directives. So going through those, particularly with family members or patients, if they have them in place, particularly if people are resistive to it, and saying, Mrs. Smith, you remember, as per their advanced care plan or as per their advanced care directive, these were their wishes, etc. So sometimes it is about going back to the wishes or the things that were discussed about previously, as obviously, as we know, when people are dying, their loved ones or even themselves emotions and things are heightened. So sometimes it is about taking a step back and removing ourselves from that current situation. So in the slide attached is a syringe driver information for patients and carers. So this was developed by our Central Coast Local Health District, by the Palliative Care Service. And That's obviously a sample version, but if anyone is interested in developing one for your facility, very happy to share them on for them to be utilised and redeveloped for your facility. So it's effectively a step-by-step on syringe the management of syringe drivers and using things like alarms and showering and bathing, etc. And we provide them to family members and patients when we commence them on a syringe driver. So it's just something that they can read through in their own time. Obviously, this is very targeted at home death and things like extra breakthroughs and medications. So you would obviously need to adapt it for your appropriate environment, but it is a good tool to sort of start with. So that's there. Now, this is a very long equipment list of what is normally required to set up a syringe driver. So I'll go through each of the pieces individually so that you know what I'm talking to. I'm not just saying, Luer lock syringe and you have no idea what I mean by that. So I'll show them as we're discussing that. So we obviously need to make sure that we have orders and prescribed medications. So that's the most important part. Can't start a syringe driver without a valid prescription, or an order being charted by the GP. So ensuring that has been activated first before we even do anything. We obviously need the syringe driver. So we're using here the BD Bodyguard syringe driver. We need a subcutaneous access device, or known as a safety intima. So I have one here. So I have it popped into a demonstration, a demo kit. So it's effectively a Chinese container with a Mepilex and the safety intima put into it, so it can feel like the patient's skin, and you can practice injecting into that as well. So that's what that intima is. We need an infusion extension set. So these are what we use. So these are 100 centimetre tubes, and they hold 0.8 mil of liquid. So the machines can only, they're calibrated to have no more than 1.2 mils primed through the line. So we need to ensure that when you order your lines, that the lines are compatible and no more volume than 1.2 mil over the entire line. We also use a Luer lock syringe. So Central Coast Health, our machines are calibrated for Terumo syringes. However, I believe your syringes are calibrated for BD syringes. Effectively, it's the same. It's just the branding as to where the caliper sits and moves along the syringe driver. But Luer lock is effectively the lock around the syringe that allows the syringe to actually turn and lock in place. So that's what that means. We need a transparent dressing to go over the top of the safety intima, so that we can see the skin directly underneath where the intima is entering the skin, so that we can look for things like redness, phlebitis, swelling, whether the line is removed or not. So always transparent. You need chlorhexidine wipes to obviously apply to the skin before you inject, to minimise obviously any risk of infection. We need a subcutaneous medication label for the syringe. So the New South Wales health expectations are these syringes with these black and brown lines either side, and that indicates that it is a line label. That's the Ministry of Health's usage. So it has patient's name, ID, date of birth, the medicines that are listed, the diluent that's used, so water or saline, the date, the time, and then the two checkers of who has put the medication together. So that we need one of those labels. And then we also use a line label for the extension tube. So I didn't bring one with me, but it is very similar to this brown one. And it essentially goes onto the bottom of the line, closest to closest to the patient, not closest to the syringe driver, and it just says when the line is due to be changed. So in theory, the lines need to be changed every 7 days, unless obviously they end up with a crack or a kink or something within the line, but a minimum of every 7 days they must be changed. So that line label just has that date on there so that staff are aware. We need what we call a needle-free valve injection port, aka a bung. So just these positive pressure valves effectively, and they're used because you'll need to put in 2 lines. You'll have one line that's going into the person for their syringe driver, and you'll need to insert another line for any breakthrough medications that they may require outside of the syringe driver. So you'll need one of those for the other line, not for the line you're connecting to the syringe driver. Don't use a bung with a syringe driver. We need a red combi stopper. So just these, and they are effectively put onto the end of the syringe, which I'll show you in my demonstration, to prevent any medication from being accidentally pushed out of the syringe if you were to drop it or bump it, etc. We also need we need a diluent. So in most cases, saline for about 95% of medications. However, we also have water for injection. So I was going to be interactive with you guys and ask when do we use water for injection, but I've already listed it in the equipment list. So I've given you the answer to the question I was going to ask. So we use it for cyclazine, as cyclazine interacts with saline. We also need a sharps container to put all of our sharps and disposables in. We need a locked box. So this is the lock box that the syringe driver goes in that you would have received with your syringe driver, and this prevents any tampering or the syringe falling out, etc. if it's dropped, and actually as a protection case for the syringe driver, because unfortunately they do sometimes drop out of error, but they're a bit of a buffer case, but again mostly for tamper proof so that people can't remove the syringe. We have a cloth bag for the syringe driver if needed. I didn't bring one of those, but again, you can use them if you need. You may need a razor if we're needing to put in a line for someone who has a lot of excess body hair and we're needing to put it in a particular location, such as usually in the legs or the abdomen is the most common places. So you cannot put in a line unless the area around it has been shaved. So you may need a razor, so just be aware. We use 9-volt batteries for syringe drivers, so ensuring that your facility has an adequate supply of these, because normally batteries only last for about 3 days in a syringe driver, and most people need them for longer than that, so ensuring that you have an adequate supply. And then also a syringe driver management chart. We use them for Central Coast Health or across New South Wales Health. If your facility is wanting to develop something, please reach out and we can forward our charts, and that your facility can adapt to your own purposes. So on the screen is a compatibility chart that has just recently been updated, so July this year. So it's very current and up to date. So our service updates this every 4 years, and it's circulated across Central Coast Health. So you can ensure that this is the most reliable information. So we don't use resources a lot like MIMS or the injectable handbook in palliative care, where we do things a little bit outside the square, so we can't rely on those resources. So we look to quite specific palliative care resources to develop these fact sheets. So it says that there are the most commonly used medications that are put together in 99.9% of the time with no problems. So that's normally glycopyrrolate, haloperidol, hydromorphone, metoclopramide, or Maxilon, midazolam and morphine, so they're always safe to be administered together. However, morphine and hydromorphone, we wouldn't be wanting to put 2 different pain reliefs in that do the same thing. We sometimes will have morphine and say methadone because we're using it for a different purpose, but normally not things like morphine and hydromorphone. We wouldn't mix two analgesics such as those together. And then where we've got a list of other medications that can be given subcutaneously, but we always recommend checking in with the specialist palliative care service just to make sure that that's all appropriate and safe. So you've got the list there, things like cyclizine, fentanyl, buscopan, ketamine, Keppra, levomepromazine, or Nozinan is another name for it, methadone, octreotide and ondansetron. So if your residents are needing medications such as that and they haven't already had a referral to palliative care, that's a very appropriate time to reach out to our service. Or if you're needing phone advice, GPs, please encourage your GPs that they can call our service at any time. They have access to our staff specialists 24/7 through the Switch network at Gosford Hospital. So please be aware that that is a resource available to your GPs. And it goes through and it explains why we use sodium chloride versus why we may use water, what medications will most commonly cause site interactions so that you can be aware and alert of those, and obviously the references that we used as well. So really good resource. Again, happy to forward to any facility that may wish to use it for your own education purposes. So before we set up a syringe driver, we always obviously need to go through the 8 rights of medication administration. So again, that's referring back to our medication chart. So ensuring we have the right patient, we have the right medications, we have the right dose, ensuring it's subcutaneous, not oral, IV, etc. We have the right dose, and ensuring, although it is a medical officer's responsibility to write the medication and the dosage down, we as nurses, as the administrators, are the final check. So if you look at a dose and it doesn't feel right and you think it feels either excessive or you think it feels very under, you have a right to question that. If anything, if we administer it and we felt, oh no, this didn't feel right, and there was, say, for instance, a typo and we administered it, the person who actually gets reprimanded is the nurse, not the medical officer. That's how the New South Wales Health look at these cases. So always remember, you are the last line of defence between that medication and that patient. So always ensuring that the dose feels right, and if it doesn't, reach out and ask someone about it, even checking multiple people, does this feel okay? The right time. Obviously, in a lot of cases, we're not wanting to start syringe drivers overnight, normally because there's less staff. If anything goes wrong, troubleshooting can be a bit more difficult. Our GPs can be harder to get a hold of, etc. So we normally try and suggest mid-morning as a good time to start syringe drivers. Again, just because it's not, and you know, there's more people around and easily contactable if you have any concerns. Right documentation, the right reason. So why are we actually starting this syringe driver in the first place? So that's always should be your first question. And if everything seems okay, going ahead, and that we're getting the right response as well from the medication of why we're actually administering it in the first place. So our next slide is, as I alluded to at the beginning of my talk, this is an under 4-minute presentation about how to set up a syringe driver. So this can be used if you're needing a quick refresher and you don't want to go back through and watch a 20-minute demonstration of me doing it or anyone else. This can be a very quick refresher for you. So I will just ensure that I hit the right button.
How to set up the T34 McKinley syringe pump.
Who can set up a syringe pump?
Any trained registered nurse can set up a syringe pump, providing they have received the correct training and have completed the appropriate self-assessment competencies. These can be found on the intranet.
Prescription. Please ensure that the patient has been correctly prescribed a CSCI on one of these yellow forms. Ensure that all appropriate fields have been completed. Where do I get a pump?
Please phone the hospital palliative care team during working hours. Outside of these times, please contact General ICU as they hold a small number of McKinley pumps for when needed out of hours.
What equipment do I need? Each ward should have their own key for the locked box on their CD keys.
Each ward will receive an equipment box that will be delivered with the pump.
It should contain a supply of 20ml Luer-Lock Braun Omnifix syringes, needles for drawing up with, CME giving sets, SAF-T intimas, clear dressings, batteries and prescription charts. Each pump should be in a clear locked box. A protective bag may also be provided. Please remember that each pump must be returned to the palliative care team once it is no longer in use.
When patients are discharged from the hospital with a McKinley syringe pump, please ensure a phone call is made to the Red Cross to arrange collection of the pump from the discharge destination. However, if the pump remains on the ward and is no longer required for the patient who it was issued to, then please return it to the palliative care team with the accompanying equipment box.
How to set up. There are instructions on how to use the pump on the front. You will find the buttons here along the bottom. At the back you will find the serial number. You will also find the battery, open and close like so. This is a computer, so please be careful not to drop or damage the pump. There are 3 detection points: the plunger, collar and barrel clamp arm. Inspect the syringe pump, ensuring it is clean, undamaged, and the barrel clamp arm is down and battery secure. Turn on the syringe pump. Keep fingers out of the way as the pump does its preloading checks once the machine is turned on. Preloading. Once the screen says load syringe, check the battery level by pressing info and then yes. Ensure there is enough for 24 hours, which is 35% and above. Next stage is to prime the line if it is a new syringe or new prescription. You must ensure you are using a CME line. Once you have labelled your syringe and primed the line, you are ready to set up the syringe pump. To load the syringe, lift up the barrel clamp arm, line the syringe up along the barrel and use the arrow keys to move the plunger to the right spot. It is important for this to be accurate and not forceful, as not to waste any medication. Once the arm has been replaced, pull the barrel arm clamp up and over to secure the syringe in place. Once in place, on the screen it will tell you the brand of syringe, 20ml Braun Omnifix. These are preset within the hospital. You are asked to confirm this by pressing the yes button. The screen will then display the starting volume, duration of infusion and rate of infusion. Once you have written these down, press yes. The screen will then ask start infusion. Once ready to bring the pump to the patient, place the syringe pump into the locked box as shown and lock with the key. The control buttons will still be accessible with the locked box in place. You may see a pump pause too long message appear on the screen. The pump will alarm and the red light will come on. This is normal and it's simply an alert to make sure the pump is attended to. And once completing identity checks, bring the pump to the patient, connect line to patient. You can then start the infusion. To lock the keypad, press and hold the info button until it beeps. Ensure the green light flashes and the main screen says pump delivering. For 4 hourly checks, you will find the infusion rate and time remaining on the main screen. And to check the battery level and volume remaining and volume infused, press the info button twice. Unlock the keypad by pressing and holding down the info button and wait for the beep. press the stop key, press and hold the on and off button. Disconnect the syringe from the line, then remove the syringe from the pump, and you are ready to start again with all of the checks from the beginning.
You must never disconnect a syringe pump from a port to give PRN medication. Also, you must never disconnect a syringe pump without first disconnecting the line from the patient.
Who can give me advice if I'm not sure what to do?
If, after watching this video, you need more assistance and support, please speak with the assigned super user on your ward. You can also contact the staff listed here.
Thank you. So I hope you enjoyed that short little presentation. So obviously it is from the NHS in England. So it's obviously their devices, similar, same device, but obviously different resources. But it effectively is the same process. But I'll be showing you what you would expect to be using locally in the following demonstration. So obviously when we're setting up a syringe driver, washing our hands and donning gloves if we need to, but at the very least ensuring that we are washing our hands before we do that. So again, your syringe drivers, as I mentioned previously, are calibrated for 20 ml syringes, so always ensuring you're using a 20 ml syringe. They can be recalibrated to run larger syringes, but that needs to be done by a clinical engineer, which the MediLogic, the company that the syringe drivers were supplied to your facilities, have a contractor that can support your facilities in managing any recalibration or servicing that's required. And also highlighting that the machines are programmed to let you know every 12 months that they're due for recalibration. So it's always important that they are serviced regularly to ensure that they will last for years and years. Our palliative care service have got syringe drivers that are about 17 years old. So if they're well looked after, they can actually last a very long time. So when we have, obviously we've got our syringe, we use our drawing up blunt needle syringe to draw up the medications that we require. So I don't have a sharps container, so I will be using my little demonstration box here during today, but effectively using the Luer-Lock syringe and then using our blunt needle. I'll just pop it down here, but obviously this isn't normally best practice because I'll be continuing to show you what I'm doing with my hands. So as I mentioned before, we're drawing up, we've got your diluents that you may need. So in this case, we will use saline. We won't use water for injection, but if we did have cyclozine, we would draw up all of the medications with water for injection. It doesn't need to be separately drawn up. All the others are safe, but as saline represents our body's structure better than water does, that's why we use sodium chloride, as it is absorbed better into the skin. So, however, another thing I wanted to highlight, you don't need a diluent to draw up your medications. For instance, a patient may be on very high dosage of medications and the entire volume of the syringe may be filled up with the medications themselves. And if that's the case, you don't have to add a diluent. The diluent is only added to bring the volume up to a particular amount. But if the drugs take up that whole amount, it's not necessary. So I have here that we reconstitute it between 15 and 17 mils. The reason being is because that's what the syringes are calibrated for, so they cannot be overfilled with any more than 17 mils. Otherwise, the calibration whacks out and the patient isn't going to get the medication requirements that they need. So always ensuring between 15 and 17 mils. We're reducing our margin of error by having those mils up at that level. We can run them at lesser volumes if needed, and that's generally if we have people that are either very cachectic, so not a lot of fat on their body, so therefore their absorption rate is impaired, or it could be that the person keeps having recurrent infections or responses to it. So if that's the case, you can run it on a lower volume, but being aware that the margin of error can increase, so their symptom control may not be as optimum if you're needing to run, say, 10 mils of fluid or 7 mils. At Central Coast Health, we don't run them any less than 6 mils because the margin of error is too high, and only if we ever have to do that, it's normally, like I said, it's guided by one of our medical staff specialists. So if you're needing to run a syringe driver at a very low volume, I would strongly suggest a referral to the Specialist Palliative Care Service for advice on that. So we obviously, say for instance, we've drawn up all of our medications. So we use our order to draw up what's required. So for instance, say morphine and midazolam, they're quite standard medications drawn up in a syringe, and they may equal, say, 3 or 4 mils in volume. So we're going to need to draw up the remainder to bring us to, say, 15. I've say 15 to 17, but I normally use 15 mils because it's just easier to remember, and it's the numbers a bit more rounded. So we're going to pretend that that is full of, we've drawn it to 15 mils in here. We will pretend that that is full of fluid of our drug that we've required. And then we remove our drawing up needle, pop it in our sharps container. Now, obviously, if that was full of fluid, we need to make sure that we don't have any air bubbles. Not that it's significant, but it's just best practice to ensure that all air bubbles have been removed from the actual syringe. So once we've got that, to prevent, as I mentioned before, we use the red combi stopper. We pop that on the end of the syringe, and then we can set the syringe aside, and that allows for, like I said, any accidental hitting of the plunger or medication coming out. So, and then obviously protecting the contents of any contamination going in. So we can now pop that to the side. Not only when we do that, we also use our medication label. So the minimum standard is that we write the patient's initial. So I'm going to say A. Smith if the pen works. And it's not going to work for me. Murphy's Law. No, here we go. Hold on. These can be very difficult to write on, so just be aware. You may not be able to see it when I show you. But at the very minimum, first name, initial, surname. If your facility has patient identifiers, like medical record numbers or anything like that, you can enter that. But if your facility doesn't have that, at least entering the patient's date of birth, because there could be multiple A. Smiths in your facility. So we're going to say the 1st of January, so the 1st of the 1st, 41 is going to be our Mr. Smith's one. We write the name of the drug. So in this case, we would put, say, morphine. And we're going to say 30 milligrams is the dose that needs to go in it. And then we have midazolam. My pen is not my friend. Nope, my pen is not my friend. And we're going to say 10 milligrams, as 10 milligrams is quite a standard dose that we may pop in a syringe driver. And then we're going to put our diluent. NS is a standard recognised abbreviation for normal saline, so you don't have to write normal saline. You can just write NS. We then have our date. So our date today is obviously the 24th of the 10th. I'm writing this and it's futile because my pen isn't working. And you're not going to be able to see it, but that's okay. We then sign it. We write the time. The time is really important. Thank you, my trusty sidekicks. Okay, we write in 24-hour time as well. That's obviously much easier normal saline. Okay, so I've had to go over my spelling. Anyway, it's given you all the time to have a breather and have a drink, so that's fine. So my very messy writing, but at the minimum, the patient's name, their date of birth. If you have IDs, using that, listing the drug names, and then the volume that you've, the dose, sorry, so 30 milligrams and 10 milligrams. In the diluent, using the abbreviation for normal saline, or H2O for a water for injection, listing the date, the time in 24-hour time, and then initialing and having your checked person sign that. So after we've completed that, they go on the syringe. Now, I always try to have it so that when it's wrapped around, I can still actually see where the plunger is at, so how many mils is actually listed on there. So not having the syringe, not having the label covering the numbers, having it wrap around the other side of the numbers. So that's a good way of remembering that. So I'll pop that off to the side. The next step with our pump, as per the video, is obviously you've got to make sure there's a battery in it. So 9-volt batteries are what their machines require. Now, as you would have seen in that video, that particular facility only uses Duracell videos. We strongly recommend not to use cheaper alternative batteries, just because the battery life can't be guaranteed. Sometimes the battery can last less than 24 hours if they use cheaper alternatives. So Central Coast Health either use Energizer or Duracell, and then we know that we get at least a couple of days, a minimum of 2 to 3 days out of a battery. So battery in, the instructions are where the lines need to go, popping the cover over, and then turning the machine on, pressing the on button. So let's make sure it's working. So the machine will preload and move the actuator to where it thinks it needs to go. Now, if the actuator, in this case, the arm didn't actually move far enough along, so you can manually move it. So if I was to sit and move the arm back, because we need to move that arm so that we can actually sit the syringe within the pump. As you can see, the syringe groove sits within this little divot here. As you can see, the actuator doesn't meet that. So you can manually move them, because sometimes the machines will just not move the full way. So you just press the fast forward button. And as you can see, the actuator will actually move, and you can just keep moving it until the little groove fits within there. So as you can see, we're still a little bit away. So we just literally move it until, sorry, doing them backwards. So as you can see, it fits within there perfectly, and then we pull the arm up and pull the arm over so that it's sitting in place. So it will say, it wants to confirm that we have the correct syringe in place. So you would obviously say yes. So what do I have here? Yep, so it tells you to wait for the automatic preload. But as I mentioned, you may need to move it back or forward. Sometimes the pump, the actuator will move all the way forward, and you just press the backwards arrow to get it to move back. So as long as you can fit both within there, the machine allows you to do that. So, and then again, we slot it into between the prongs. So we've turned it on, we clarify that we've got the correct syringe, and we say yes, which it actually gives you the instructions. So if it's not the correct syringe, you obviously go up and down, but try and use the same syringe within your facility, and it tells you to press this arrow that you have the correct one. So we've pressed that. It wants to confirm, obviously, the volume, the duration, and the rate. So as I mentioned before, if you've got about 15 mils within, it's around about that 0.63, 0.64 of a mil per hour. So it will work that out perfectly for you. You need to make sure that the duration is correct at 24 hours. So we want to say, yep, that all looks good. So we press yes. However, if we want to prime the line, we don't want to start the infusion. So this is when we're commencing a syringe driver. So we would actually say, so we've got start infusion. Sorry, I'm just going to have to turn. And you press the forward arrow button and it says purge. So we don't manually purge the lines because that can throw out the calibration. So we always want to let the machine do the calibration, the purging for us. So if you don't do it quick enough, it'll just revert back to the start infusion page. So we can just press the purge button again. So what we do is, obviously we have one end that goes to our patient and then we have one end that connects to the syringe. So we just remove the bung with that. We remove our combi stopper and we connect to that. So again, it'll go back to that page. You just keep pressing that where we say purge and we want to go press the arrow to confirm. And then we press and hold the arrow button to purge the line. So 0.8 of a mil. Sorry, you just got to press and hold it. So it will normally stop after a certain amount of time. But we're going to go to about there. So you can watch it come all the way out, and sometimes you'll wait until the fluid actually reaches the tip and you can watch it doing that. So we're going to say, yep, we've purged our line. So it will revert back to say that we've got the 20 ml syringe. We want to say, yes, we still have that. Now we want to resume. We don't want a new syringe, because if we say new syringe, then it will go back to the original amount and it will say we've got X amount of mils run over 24 hours, where we don't want that. We want it to run it at less than 24 hours for the initial reload with the change of the line. So we want to say, yes, we're resuming. And then we'll see that we've got now 14.4 mils and we do have a reduced duration, which is, again, expected for that initial running of the pump. But the rate has stayed the same. So that means that they're going to get the accurate dose. So we then press to confirm. We've now gone to the patient. So sometimes we can do all of that. We then come to the patient. So again, all the instructions are on the screen as well. We need to ensure that we have the intima injected into the patient as well. So as you can see on the screen, with the clear occlusive dressing that goes over the top so that we can visually inspect the skin underneath. And there's also a little sticker beside it that has the date that the line was put in. Now, Central Coast Health, we change these every 7 days unless otherwise indicated. So if the patient, if their skin becomes red, swollen, inflamed at tissues, etc., then obviously they need to be changed sooner than that. But at the very least, every 7 days, these must be changed for infection purposes. So, as I mentioned before, if we're connecting it to a syringe driver, we don't add a bung. So this, no go for syringe driver. We only use the bung for the PRN line or the breakthrough line. We don't use it for the syringe driver line because we have higher risk of occlusions and malfunctions happening if there's a bung in place, so we don't use them. So you've ensured you've got your bung, you've primed your line as per the instructions on the page. And then we connect the line. We've already done the purging as what it says on the line. So normally 0.8 mil is enough to prime the line, but you can run it a little bit more if you didn't quite see where the water ran to. They are programmed to stop once they hit about 1 mil. So that's when we go back into our 8 checks, making sure we've got the right patient, the right drugs. Sorry, they do beep, so they will say pause for too long. So if you've been talking for too long or explaining things to a family member or a patient, the machine will beep and pump and alarm at you. It is fine. You just press yes and it will go back to the page to say start infusion. So don't be alarmed if it starts saying that. So again, we've done our checks, we've connected it to the patient, and we say, yes, we want to start the infusion. So you press the little green, means go, and that's it. The machine is running and delivering into your patient. So the next step is we obviously want to make sure that the machine is tamper-proof. So that's where we have this little button on the end, the little I+ button on the end. So we press and hold that, and you'll see it says keypad lock. We hold it until that line goes all the way over to say on, and the keypad is locked. So I can be pressing up, down, forward, back, play, all of it doesn't work. The only one that will work is the stop button. So even when the keypad is locked, you can pause so it will stop it. So obviously that's a fail-safe built in. But if you've accidentally hit the red button, you can just press the green button and it will resume, and the screen is still locked, okay? Now, obviously, if you need to check the battery status, so Central Coast Health, we change the battery once they hit below 40%, and that's obviously for because we know that we can guarantee that the syringe will last at least 24 hours before that, but under 40% we can't guarantee that the syringe will run the entire 24 hours of its life. So if you've hit below 40% when you change your driver, then change your battery. So you'll be able to see that from pressing the I+ button. So as it locked the screen, it gives us the infusion summary. So the VTBI that you'll see here says volume to be infused, so it's still saying there's 14 mils left. And if you press it again, it tells us our battery level. So our battery level is full, 95%, which is great. And then it just takes you back to the screen. And then when you need to unlock the pump because you need to it's the 24 hours have passed and you need to reload it, you effectively just press and hold until the keypad lock goes to the off, and then you can manipulate and press all the other buttons. But again, pressing and holding for this case, we're just going to be locking it. Okay, and then move that out of the way. And then we need to ensure that we're popping it inside the lockbox before we leave the patient. So it's a snug fit. So, and then your syringe drivers would have come with keys, multiple sets. If I can get the key in right, and then it's just one single turn to lock in place and then removing the key. So it's very, very simple. And then our pump is running. And that will run now for 24 hours. So we'll sit that over to the side. Does anyone have any questions or anything in regards to the setting up of the pump, or any burning desires before I move on to the next component?
Yeah, there is one question that's come through so far, Tara, from Shannon. Do you need to document how many mils of normal saline has been put into the syringe?
Not on the actual syringe driver label itself. So it is best practice to write that in your notes, but it's not a necessity. But it doesn't need to be written on the actual on the label. You just have to write what the diluent is. If we needed to audit it, if your facility needed to audit it for any reason, they can review what drugs you actually put in the pump. But in theory, you're just running that through with your colleague. If you've worked out, 5 mils is needed in the actual drug volume and you want to top it up to 15, then you're going to need 10 mils of saline, but you don't actually have to document it on that. But if you want to write it in your notes, you very well are welcome to do that.
For questions at the moment, but please type them in and we can utilise Tara whilst we've got her. We've got about 15 minutes left, so we'll try and squeeze in some more time at the end for the questions.
Lovely. So I'll move on to my next couple of slides. So these are in regards to the troubleshooting and things to observe and check. So I've got a sign there that shows where the best places are to put syringe driver lines. So best best practice is generally thighs, so the front of the thighs, as you can see from the image, and the stomach. They can also be put in the chest, so the upper chest. They can be put in the upper arms, so above sort of halfway up your arm and up here. Towards the back of the arm is actually where more of the fat is. You've got more muscle towards the front, more fat to the back. So if you remember, fat to the back rhymes a bit better. That's a way that you can remember to pop it there. And then obviously you can do it in the upper back as well on the scapula. The only time when I would normally recommend to put it in the upper back is when you have people who are agitated and actively pulling out their lines. Otherwise, always in the front where you can visually inspect it quite easily, where obviously on the back you're at higher risk of the line occluding, and then you're not, obviously it's more difficult to visually have a look at the site. So that's why thighs, because they generally tend to be easier. You can just do a quick flick of the blanket, have a look at the patient's leg, where normally with a stomach you might have to pull up, you know, a gown or expose a patient as well. So that's why normally I said thighs. So as you can see from the image, you can see what a inflamed site looks like. So that redness, if you see anything like that, immediately stop the syringe driver, remove the line, let your GP know and re-site into another area. So if that happens, say, on the right thigh, we wouldn't recommend you putting in another line in the same thigh. We would recommend rotating it to the other side. We also recommend, if you've got one line for your syringe driver and one line for your breakthrough line, you have them on opposite sides of the body. Again, for minimising infections and things, it's just best practice. So either side of the body, and if you've got, say, one in the right leg for your driver and then your breakthroughs on the left, and the right side where the driver is tissues or has a problem, don't pop it in the left thigh, pop it in the right arm. So move the site entirely, or pop it in the abdomen. So the minimum checks are that you need to look at it and go and review the patient 1 hour after commencing. However, we know that the syringe driver does not reach steady state until about 4 hours after. So if the patient is still experiencing symptoms within that 4 hours of starting, that is normal. Reassure them, reassure the family, but ensure that checking at 1 hour just to ensure that everything is going okay, that we haven't had any significant reactions, because obviously they would start to occur at that 1 hour mark if that was the case. And then 4th hourly after that, checking the site. Like I said here, checking the syringe driver, making sure the rate, the volume to be infused, the flashing light indicator, so there'll be a little blinking that will normally happen on the on button. At night, it's obviously much easier, so you can see that little button there. At night, this button will be a lot more obvious. In the day, it's not so much, but of a night, that can be a really good indicator. Ensuring the battery percentage is adequate and that it's not alarming. And then obviously checking the site, so making sure that there's no redness, inflammation, anything along those lines. And then checking the actual line, so making sure the line is free of any kinks, it's straight, they weren't laying on it, anything like that, that can be causing problems. Making sure sometimes you might, every now and again, it happens very rarely, but I've seen where the drug will appear to crystallise, so you can actually visualise it in the syringe. So we always say do a quick inspection of the actual syringe. So normally the back of it, where the sticker is exposing the syringe, so you can make sure it's not crystallising, going cloudy, a different colour, etc. So always a quick look at that. And then making sure there's no leakage. Sometimes if the line isn't done up properly, it can be leaking from the site, from the entry point here, and also at the patient. So making sure that there's no leakage as well, and that the patient's symptoms are adequately controlled as well. So assessing those symptoms. So here is the Central Coast Local Health District syringe driver observation chart that's used widely across the service. So again, if you'd like a copy of that, please reach out and we can ensure that one gets to you for your facility to adapt to your local procedures. With troubleshooting, again, if the syringe driver is alarming, there can be numerous reasons for that. The main thing is that it's complete, so the actual infusion is ran through its 24 hours. It will start to alarm, and it will also alarm when we're very close to the end of the program. So ensure that that is the case. Sometimes the syringe has actually misplaced and it's moved off-site, so it will actually alarm to let you know that. If the line has been disconnected, so either it's disconnected from the patient or from the actual syringe itself, it can detect that, and that the patency of the butterfly is actually flowing. So if there is an occlusion, it will come up on the screen saying line occluded. The machine is built in for a particular pressure, so once it senses a particular amount of pressure, that sends an alert back to the machine to alarm. So, and that can be as simple as a patient laying on the line can be enough to completely occlude it. In most cases it's not. Majority of patients can lay on them and they are okay, but it's always best to try and remove it from the patient. But a total kinking of the line for a number of minutes will cause the machine to beep and alarm. So always check all of those things. Look at the screen first, see what the screen has to say, and then go from there. Unlock the keypad. So obviously that's something that you need to, if you're needing to fiddle around with it, unlock it. But sometimes it could be alarming because you forgot to lock the keypad and a button has been pressed and it's now thinking you want to do something with it. So ensuring that it is locked and then unlocking it when you need it. So obviously the do's, we need to make sure we check the compatibility, use that compatibility fact sheet that I spoke about earlier, explain it to the resident, explain it to their relatives what's going on, why we're using the medications, what they're for, how we expect their symptoms to be relieved because of that. Check the patient regularly. That's obviously the most important thing. Ask any questions if you're unsure. Reach out to the palliative care service. Speak to your colleagues, your GP, your care facility managers, all of those people. Make sure you have sufficient drug and battery supply. So that's where we find residents have come unstuck in the past. So when you have a patient that's about to start a syringe drive or you're thinking you might need to start it, check your cupboards. Make sure you've got adequate supply for at least 7 days. To ensure that you can maintain that patient on that syringe driver for that entire time without running out of medicines and then them needing to have no analgesia on board because our service is unable to deliver medications to another facility. That's against our policy, so we're not able to assist in that way. And also batteries, that can obviously be a major undoing if you don't have enough batteries. Then you can't run your pump, so ensuring that you have adequate battery supply before you start a syringe driver is obviously important. We don't want you to be afraid to use syringe drivers. As I mentioned before, they are purely a nursing tool. They don't provide any better analgesia per se, but they are a good tool that can be utilised to better improve symptom control, to allow adequate supply of medications instead of having those peaks and troughs. We don't like them to be used for very agitated residents, obviously, because then if they're constantly pulling out the lines, then it can become more of an issue. Sometimes regular intermittent medications for very agitated patients is best practice. As well as the heightened risk of when you've got very agitated patients, them flinging them, the machine's becoming damaged, they're very expensive. So we obviously don't want them to be broken. So very agitated patients, I would be strongly suggesting against it. They can't be wet, so they are not waterproof, unfortunately. They can't be taken into a shower. If a patient is showering and has a syringe driver, they need to be put into a waterproof bag, so a plastic bag or something, and moved away from the side of the water, because if water does get in the machine, they are rendered unable to be used. We don't recommend placing them on bedside tables. Obviously, you've got then a line that's coming off the bed. You've got higher risk of the syringe driver falling, risk of people trying to tamper with it, etc. So always best practice to leave it within the bed as close to the patient as possible. Also not overfilling the syringe. As I mentioned before, the syringes are only calibrated to a certain amount of volume. So in a 20 ml syringe, you can't run any more than 17 mils within it because the calibration fails. And if you have a syringe that's if you have a pump that's needed to be calibrated to a 30 ml syringe, they can't be run over 22 mils. That's the maximum volume that they can manage. The only reason why you may need to increase someone to a 30 ml syringe is if they've got lots of symptoms, so they've got lots of medications and they've got a high volume of medicines. So sometimes we do need to have a higher volume. So if you're needing to recalibrate your machine, reaching out to MediLogic for that. and don't set and forget. They're not set and forget devices, making sure that you're reviewing them every 4 hours at the minimum. And do we have any more questions?
There's none coming through at the moment, but please type them in now if there is any final questions you'd like to ask Tara before we do finish the session today. I'll come over. I do have Slido here opened on my phone, so please, send in any last questions. We've still got about 5 more minutes, if you can stay with us. I'll just get my colleague Sandy to just launch the evaluation poll as well. So we'd really appreciate it if you could fill that out before you log off today. Your feedback is really important and it helps us to demonstrate the success of this project at the PHN. And also nice for Tara to get some wonderful feedback. There's no questions that have come through yet, Tara. I think you must have
Answered everything,
You did.
hopefully.
I'm sure you did. It's been, a wonderful presentation, very informative, and I think everyone would agree that the practical demonstration going through the devices is really effective to see that, particularly when, we can't always get to every facility. So
Yes.
That's been, I think, really, really useful.
I suppose please know as well that if you have, as I've mentioned numerous times throughout the presentation, if you have any significant issues with syringe drivers and you need advice, like I said, you have obviously your MediLogic services as well, but if particularly around dosages or you need to question things or you have any uncertainty, our service is very, very happy to assist your inquiries in regards to anything along those lines.
Great. There's just a comment from Anna saying thank you. Great information.
Thank you. Always nice to be well received.
All right. Well, I think we've given opportunity for any last questions. There's no more coming through, so we'll wrap up the session there. So thanks once again, Tara, for generously giving your time this afternoon. I appreciate how busy your service is. So, thank you on behalf of the PHN and on behalf of our facilities watching today. Thank you as well for giving time in your very busy afternoons to spend it with us. And we hope that you got a lot out of the session today. And we very much promote that model of train the trainer, I guess. So we hope that you can share this knowledge that you've gained today with other members of your team and continue that education so you can continue to provide best care for your residents, and we really appreciate everything that you do to support your residents at end of life. You're all amazing, so thank you very much. We'll wrap it up there. So we hope you enjoy the rest of your afternoon, and thanks for joining today.
Thank you.